And we're going to be talking a little bit about the process of data reimbursement for each facility, just to refresh memories, or if you had not heard this before. We like to have a week-to-week stipend. It's nominal, but $50 stipend for delivering data from your facility, each week related to our homework. And so we want to do an accounting of that. So, for example, we have a couple of facilities that submitted through the Dropbox option their root cause analysis, which is wonderful. Thank you for doing that. But we'd like to get credit for everybody else if you are doing your root cause analysis, just to share that with us. So that would be good. And then today, we're going to try to be a little bit more interactive. So if you could roll your sleeves up and get ready for a little chatting and, unmuting, that would really be spectacular. As mentioned earlier, we'd like to get these sessions a little bit more working as we go along here and sharing our experiences, and then commenting on some of the either barriers or some of the solutions that we came up on. My absolute favorite, by the way, was one of the facilities that reported early in the pandemic an intervention with their residents of having model race car races. And so apparently the staff got pretty involved too. So they had the whole facility, racing these little, remote control race cars up and down the hallways. We didn't hear of any issues about falls, but one can only imagine. Good. All right. So today, excuse me, sorry. So today we're going to follow the QAPI at a glance framework. And so Gene Rowland from Quality Health Associates and myself will be the discussants today. So we're a little bit of a tag team. So thanks, Gene, for helping in with this. And our topic today is step 2 of the QAPI at a glance, which is to develop teamwork towards QAPI. And then also we're going to discuss concepts behind data, both in terms of identifying baseline data and then benchmarking, which are two really the nuts and bolts of QAPI. So today we're going to have a little bit of a different kind of poll. So I think that's our next slide here. Is it, Sarah? Oh, yeah. So let's do the poll now, and then we'll go back to those questions. Yeah, that'd be good. So if you don't mind responding to these poll questions. First one is, do you have online curriculum to train new and existing staff on QAPI? The second question is, do you use the AHCA resources to train new and existing staff on QAPI? And then number 3, do you have a pre and post-test methodology for evaluating QAPI knowledge of staff before and after their training? Number 4, do you have a yearly QAPI knowledge and maintenance program for staff? I kind of laugh at that because the University of North Dakota has annual training on falls and how to pick up large objects without, so back injury program. I have to do this annually. What format? Number 5, what format would best serve your staff for QAPI education? So this is just, we're trying to get a little better handle on what you think would be the best options. And you can put more than one if you wish. And then lastly, this kind of new concept that came out of the University of North Dakota, which is called digital badging. So I don't know how this might, float the boat with some folks, in terms of, but it's a lifelong digital badge that's retained at University of North Dakota. That could be used as part of your curriculum vitae for staff members, and like I say, it's an attestation or a basically a backup report that says that somebody had completed QAPI training. So if you don't mind just filling those questions out, and we can take a peek at those answers here just to share our thoughts about this process. All righty. Yeah, okay, good. So question number one, so people are accessing an online curriculum, and do you use the national resources? So kind of evenly split behind that. So it'd be kind of interesting to know for those that don't use those resources, and we'll have some message here from Vanessa a little bit later on about that whole AHCA process. Item number 3, post-test methodology. So again, we're evenly split on that, and good to know this because in order to know whether we're effective, with our any kind of training program, it's good to have some type of baseline knowledge about the training. And then looks like most people have a yearly maintenance program, so that's fantastic. Congratulations on that. And then looking at self-paced modules seems to be the preference. Yeah, I agree with that. It's just, reminding folks to do those self-paced modules is always an issue. Yeah, okay, so the digital badge looks like, a little head scratching there. So I threw it out there as a question, something to think about that might help motivate staff members that, that they acquire this digital badge. It's a new concept. So I'm not surprised that most people are, like I say, kind of scratching their head as to, what the heck that means. But something we can explore in our conversations down the road here. All right, Sarah, do you mind? Can we go back up one slide, please, to the? So we wanted to. So this is kind of the open-ended questions. You can either use the chat box, or if you want to unmute yourself. Just a few questions here. So the first one is. Any thoughts from folks if you use the scripted walk-rounds format? Did it work? Was it awkward? Did you discover something? So I guess if it'd be great if somebody could unmute themselves if they did use the structured walk-rounds. Billy says staff still seem hesitant to share concerns. Yeah, so That's an interesting barrier. Does anybody have any ideas as to why staff might be hesitant with sharing their concerns?
Hey, Dr. Jurevich, it's Kelly.
Hi.
Hey, I just wanted to make a note on that. At the end of the phase 1 sessions, we talked a little bit about really trying to frame all of these issues or concerns you see as opportunities for improvement. So really try to take the negative connotation out of it, and then maybe people will be a little more apt to, give you feedback.
Yeah, that's a very good point, and I think the structured or the scripted walk-rounds actually has statements in the beginning that says, today we're going to look at some issues that you've observed. Nothing's punitive here. We're not trying to get people in trouble. Rather, we're trying to look for ways to improve. So again, those I call them icebreaker statements, and basically there's about 6 different opening statements that you could use, and you can rotate those statements with your walk-rounds. And see how they go. Obviously, if you're doing walk-rounds, the idea is that you do the walk-rounds in a limited fashion. It doesn't have to be the entire facility, but you can use the opening statement, with different units on different days that you do walk-rounds. I think people do walk rounds either daily or weekly. It seems to be the consensus. Last time we did the poll on that. So again, just adapting those questions and rotating those questions, those opening questions could be helpful in structuring. And again, if staff still see some issues or barriers to that about, being hesitant to share their concerns, then you would go to step number 2. Obviously those icebreaker reflections or questions or comments may not have the impact at your particular facility. So then a little deeper dive may be needed to figure out. And so using focus groups, for example, is like, when we do walk rounds, we're noticing that we're not getting a whole heck of a lot of information, just kind of wondering, what your thoughts are about that. Because I think the other consensus that we found out is that the drop box, the suggestion box, that's another source of getting information, doesn't always seem to really rally the troops. So I think that direct communication is valuable. All right, well, thank you for the feedback on that. And if does anybody want to comment about that, about the hesitancy, in addition to Kelly's comments? Okay, well, if you do have some thoughts along the lines here, this is totally open for discussion as we move along here. So if you have some reflections or thoughts about your own walk rounds, again, please share them with us. The next question is, how did your root cause analysis go? So anybody have any comments about their RCA? And secondly, did you get a chance to use the loneliness scale? Just getting back to the walk rounds. Let's see, Leanne just comment that that your walk rounds didn't have a problem sharing, so that's good. So there's a sense of openness. Yeah, and I think that really reflects the facility to facility variation that we would expect. So the question there becomes what positive things allow the staff with Leanne to be perhaps openly more expressive of their observations. So I don't know, Leanne, do you have any comments about why it's working so well for you? Okay, so in the chat session, just getting back to the loneliness talks are taking about a half hour per person. Huh, interesting. So that it seems like you have a little lengthier process other than the loneliness scale. Is that correct, Leanne?
Okay, so we got 2 different conversations going at the same time, and I can't keep up. So with the walkarounds, this is April, and I've worked at Missouri Slope for 10 years. I worked on the floor prior to becoming a unit manager, and then taking the QAPI director job just this last year. So I already have, a lot of relationships with the staff on the floor. So I guess maybe that's more easily approachable, I guess. And I also pull in a lot of employees to do PIPs with us. And so they're used to me, plus I teach CPR. So if they had a CPR class with me, they're like, oh yeah, I know April. So I think it's just having that, just being well known, I guess. I don't know. It makes it easier to approach, but they're not afraid to tell me what they think, which isn't always a good thing. But what we're finding is that we really needed to scale back on our PIPs because they're just tired of them. It's been with COVID, the QAPI process is part of the guidance, and so we have to do it. We literally have been doing QAPI on PPE, hand washing, shared equipment, monitoring, cleaning for a year, and they're like, yeah, we got it. We know how to do this, but we still have to keep continuing to do it because it's in the guidance. So it's really frustrating for them, but I make sure they know that, but they're just tired of doing it and they want to do something different, but we can't stop the ones we're doing. So we're just adding on more work for everybody by doing more PIPs, you know. So it's just, I try to use different groups of people to do different monitoring so that it wasn't just one group doing it all. I have the cafeteria monitoring PPE usage and storage in while people are on breaks. And then I have the nursing team doing cleaning equipment between uses, hand washing and PPE use. I have the front office monitoring PPE use as people come and go through the building. I do my own cloppy PIP on new admissions and readmissions to make sure they're placed appropriate rooms and vaccination. I mean, it's a lot. So we got a lot of moving parts. So the loneliness scale, I did hand that off to the activity team. And, you know, the residents, when you ask them that first question is, are you lonely? Well, everybody's lonely because they're tired of everything. And they just want to talk. So, you know, you're not just going in there to ask them 5 questions. You're going in there to spend at least a half hour with them and let them vent to you about how sad they feel. And so it's taking a lot of time to grab that information, which, you know, once I get to the loneliness scale, I can guarantee that almost every resident we've talked to will be high and lonely. And unfortunately, our community, we're in Burleigh County, North Dakota, it's going back up in COVID cases. So, I mean, it'll only be a matter of time before we have to start testing twice a week again. And, oh, you know, it's just, it feels like we're starting all over. There's no visitation, you know, it's just, it's frustrating. So.
Yeah, thank you for sharing all that information. Just some pretty amazing observations that I'm sure others can reflect on. You know, one is the PIP fatigue, and you know how to best manage that. I guess you know the and so that actually could be a good work session for us down the road here. That you've identified, you know, in terms of how to, you know, avoid PIP fatigue. And it sounds like your distribution of workload is spot on. For one, you know, by doing these handoffs to other departments and you know, groups within that. So that's good. I'm seeing some really interesting comments though about the loneliness survey. So. April and Leanne, I appreciate your feedback on this. You know, for one, that it sounds like the survey itself was a somewhat of a conduit for therapy, and it just kind of makes me wonder, just by simply asking those questions. It's much like reminiscent therapy, right? You know, you ask people to reflect. So I think you're onto something there that we might want to think about and, you know, like I say, dissect a little bit more in terms of whether these surveys can also serve as a point of intervention, and how would you measure that, right? As a point, and it gets to this concept that's occurring nationally, where older adults are being integrated into this framework called age friendly. We really haven't had a chance to talk about that, but just one of the aspects of it is to use the geriatric 4Ms with older adult encounters. And these are all clinically based, of course, but the first M is what matters. And, you know, I'm looking just kind of at the chat box here, and the one comment, let me just see if I can pull this down here. Hang on for 1 second. So Andrew Johnson was talking about the revelations of the century here, that some of the residents preferred to be secluded and enjoy their alone time. So just the opposite, you know, if somebody's impinging on their, you know, space or whatever, right? You know, so that's the other end of the coin that needs to be addressed. You know, do they have enough? You know, do residents have enough? Whatever you want to call it, you know, self time or whatever. Good. All right. So I think these are just really fantastic comments. Let me just go through the chat box one more time here at the bottom. So Sarah was mentioning we did our loneliness surveys, and looking at the outcomes, where surprisingly half of our sample do not feel lonely. They do state they miss time with their family, but feel that the staff have done well. Yeah, that's fantastic, getting that information. So again, reflecting on that kind of feedback is, what are the things that are making that connectivity happen, and trying to identify those key points of interaction with the residents. Certainly could be something that would be shared, or could be shared with our group to identify best practices. So this is really spot on. So all these kind of observations and reflections help us think and do a little bit, like I say, a deeper dive into what is working. And I think the best example thus far from our conversation has been that element of the aspect of the structured rounds. One facility having a little bit of resistance, another facility, because of relationship building, has a pretty good conduit for conversation. So again, what are the elements that can help elevate the conversation with a facility that may be getting a little bit of resistance. So I think those are important. All right. So we're moving on to the next slide here. So we want to hand off to Vanessa to talk about the QAPI through ACHA. So it's all yours, Vanessa.
Thank you, Dr. Jurevich. Hi, group. It's nice to see you all. I just wanted to let you know that we did some checking into the HCA QAPI program, and the current program that they have, they actually are looking at revamping it and rolling out a new program starting in May. We just got some initial information here that they are looking to do a self-paced course in conjunction with another association, and along with that, having a QAPI certified professional program where members of your committee could become certified and then help lead the programs at your facilities as a certified professional. And it does look like a lot of what we're covering here with Dr. Jurevich's group, conducting your root cause analysis, leading effective meetings, using team decision-making techniques, becoming comfortable using data to drive improvement, and then also working through PIPs with your group. So it looks like it's a interesting program coming forward, and they are looking to roll that out in May, sometime in May. So watch for that. That's something that Peggy will send out to the North Dakota facilities. And that's what I know so far as upcoming QAPI from AHCA.
Yeah, that's good. So looking forward to that curriculum. So there's so many ways to enhance QAPI knowledge. I think on one hand, the ACHA program appears to be focused on identifying QAPI experts, and which is good. So QAPI directors and so forth, as facilities have QAPI, 10 years ago, there was, when I was working in a nursing home, there was no QAPI anybody, right? In the facility, there was just basically the administrative and the director of nursing. But now, there's a distinct position for a QAPI director, which is wonderful. But I think really one of the important things for us to consider is, in the trenches, the direct workers, how they're engaged with QAPI and can be leaders, to really stimulate their interest in identifying problems that are potentially solvable through teamwork. So that's kind of our focus, is to try to integrate the direct care workers and elevate their game in this process, and to do so through this initiative. I'll also follow up with Vanessa's comment that the AHRQ, which is sponsoring this particular series, is meeting this afternoon. So like, right after the session, I'll be meeting with the National Collaboration to get their report on how they're going to move forward with what we call, we're in phase 2 of the COVID Action Network, through what we call the ECHO program. And so we're going to get a little bit more clarity, and I'll report that out at our next meeting as to what they're looking forward to. All right, so thank you, Vanessa. So we want to move into developing a deliberate approach to teamwork. So I'm going to hand this off to Jean Rowland. So Jean, it's all yours.
All right, thank you. So Harry Truman once said, "It's amazing what you can accomplish if you do not care who gets the credit." And today, when I was thinking about this teamwork presentation, I thought this is so true, and this is really a virtue of a highly effective, one of the many virtues of a highly effective team. So, as you're all very well aware, through your past work with Michelle, teamwork is a core component of the QAPI program, and it's fostered evidently through the values and the mission that are set by our leadership in each organization. Next slide, please. There we go. So here on the screen, you're seeing the QAPI at a glance characteristics of a highly effective team. They list 3 of them. The first is having a clear purpose. There is responsibility that rests with leadership to provide training to staff and to define each individual staff member's responsibility to QAPI. So as you think about this and leadership's responsibility here, 2 very important steps that you can take to assure that this happens is to identify these responsibilities in job descriptions, and then to review these responsibilities on an annual basis in evaluations and so on and so forth, or as needed. There's nothing as valuable as having real-time feedback and reminders set in place. The second characteristic of a highly effective team is having defined roles for each team member. And here, again, leadership should support this idea through their actions and the provision of resources to make this possible. And the third characteristic is committed active engagement from each team member. And obviously, this has to be an individual responsibility, but it has to be a predefined responsibility for each person who's on the team. Next slide, please. So as I continue to go through this higher level overage, I guess I'd say, of teamwork, I invite you to take a moment and to chat in the attributes of a team that you have encountered in your organization that has either been, extremely successful, or even one that has been extremely unsuccessful, and with those teams, what would you do differently moving forward? So on the screen right now, you're seeing just basics, the basics of teams. In our QAPI at a glance manual, we see that task-oriented teams are more focused on particular problems, and that there's a limited and more focused time with each topic. PIP teams, on the other hand, are generally formed for longer-term work on a very specific issue. So it is recommended in our QAPI guidelines that when chartering a PIP, careful consideration should be given to the purpose of that PIP when looking into what team members you want to have, or what members you want to have available on the team. So here it's important, I know we've talked about this a lot in the past, but to acknowledge the value of multidisciplinary teams and what persons who aren't even closely engaged to the topic at hand can bring to the table. Also consider the value of family members and residents as team members. Here you sometimes have to be cautious about the information that's shared because of HIPAA rules and so on and so forth. But especially residents can bring a lot of good information to, or good ideas to the table. Teams should always plan for sufficient communication. I say that good teams communicate often and openly. And you want to have a good communication plan set in place, have at least one face-to-face meeting planned so that everybody can meet each other and get to know each other. And then, you know, look into how each team member communicates best. Some persons prefer electronic communications, other paper communications, but see what works best for your team. And you may have to try several different modes of communication to find what works best. And then again, as mentioned earlier, leadership support is absolutely essential to the success of a team. So I haven't looked at the comments that came. I think we only had one here. They had a poor success at, let's see, oh, that was Dr. Jurevich, turnover of team members. Yeah, and Leanne says that getting everyone at a meeting can really be a challenge. Here again, I think this is where you can really look at the method of communication that you choose. Having electronic team communications can work, as we all know from COVID, can work as well or sometimes even better than having face-to-face meetings, and are much more convenient for a lot of people. I know that scheduling them can be a challenge, especially when you want representation from the various shifts and whatnot in an organization too. Do you have anything to add to that, Dr. Jurevich?
No, I think those are all very good points. Set aside time, and I think it's really important to structure time. So some of these can be integrated, in the teamwork. So the walk rounds are, I think, a no-brainer, right? You can use those for QAPI purposes, but then also just specifying time for staff to either sit down, reflect, either focus groups, small groups. So one of the techniques that I found useful as a medical director was to sit down with small groups of CNAs, like a half dozen or so, and they had 15 minutes set aside for them. There was coverage for their duties, and we sat down. We had discussions about. Actually, it turned out one of them was anger management, both for residents, family members, and staff. So we talked about all that because there was a lot of unfortunate altercations going on, and we wanted to kind of tone down the the hostile environment. And so we had those sessions in small groups, and it worked out quite well. And I think overall we had an impact on what we were trying to achieve. And our root cause analysis on that one was injuries, as a result of, these different altercations and numbers of police visits to the facility because family members were calling police. It was quite extraordinary, quite an experience. So anyways, that would just be my commentary. Use different techniques for team building.
Mm-hmm. I see that Melissa Smith chatted in. Our PIP has great success. They meet every Thursday at 2 p.m. So they have a defined time that they meet. And I think meeting weekly is very important.
Yeah, I would echo that. That's fantastic. Setting aside, a specified time and location is good. And then also communicating the results of those meetings to larger groups, right? So if you're working with a smaller group, having meeting minutes or bullet points that can be shared. This week's meeting of QAPI identified the following issues, and these are our plan, do, study, act cycles as a result of that. Something to that effect. That's good. Thanks for sharing that.
I think we can move on to the next slide.
Good. Yeah. Okay. So that we're going to talk about baseline data. So I want to march through this. I'm going to go back and forth between some notes that I have from Michelle Lochner, who developed this. So basically, we want to talk about benchmarking, and the data that we use for benchmarking are usually used as a standard for comparison of data that we collect from our particular facility. So that it helps us pretty much compare how we're doing at either the local, state, regional, or national level. Although sometimes I wonder, comparing to national data always makes me wonder. When I was working with the Veterans Administration, they compared our clinical productivity with my group, my geriatrics group, with national standards, and I actually got a call from central office asking me why we were working so hard. It's like we were so far off the scale in terms of number of patient encounters that I guess we were reprimanded. I have no idea, but sometimes these national standards can be a little bit odd, and I just say that in passing. They're useful for baseline comparisons. And so you might use the benchmarks from either the Casper reports or looking at CARE Compare, which are house those national databases. And I don't know, Kelly, do you have any comments about benchmarking data sources, or Jean?
No, this is, some people may have a system that you use. I know when I was in a facility, I used Team TSI, something similar that can pull your quality metrics for your comparisons against the state and national average. And sometimes those are even connected within your organization and you can compare with your peers as well.
Yeah. Yeah, and I think it depends on what your intention is, right? So using national or local data on falls may be, a reasonable approach for getting your baseline or benchmark data. But on the other hand, you can produce your own benchmark data. And I think, for example, we talked about hand hygiene. Everybody wants to make sure we're doing, 90% or better on hand hygiene. That's a benchmark in of itself, so you have to establish your own benchmark. In the month of April 2021, we're 65% compliant. And so we want to go to 90%. So what are we going to do? So that's our benchmark, right? And the benchmark changes from time to time. So if you, for example, achieved a goal of 90% or better, then the next benchmark would be 95% or better. So it's a little bit of a moving target when you have your benchmarks. Once you reach to a certain point, the question then becomes, can we do even better? And how do we get to that next level? So it's a continuous benchmark realignment with your own data, if you're using that as your baseline. Okay, next slide, please.
Dr. Jarovich, I just wanted to add one more thing. If you
Sure.
looking at something more internally, like you say, hand hygiene, I would be careful to compare that to any other provider or your peers or anything like that, because it's not set data that you're collecting that can be consistent with another facility. Whereas when you're looking on Nursing Home Compare or PSI, it's specific data that's pulled from the NDS. So it's more consistent across the board. Whereas if you're doing something facility specific, it needs to be compared to what your internal baseline is, not a national or state average.
Very good. Okay, so the next slide is the question of how to establish baseline data. So these are the initial measurements of the data that you want to collect. So you can see an example there, where we're looking at pressure ulcers, and you have a numerator and a denominator. You divide that and you get your facility observed, percentage, and then you can compare that to the state average and then the national average. So that basically allows you to give kind of a bird's eye view of what your data is relative to other groups. And the important point is that having that baseline data, it's a point of reference, and then it allows you from month to month to see how those changes. Now, it's important to really keep the data as fresh and as current as possible. It has to be real time. If some changes occur and you reflect on it, 6 months later, you go well, that was 5 months from the initial data baseline. that you had an opportunity to impact and make changes. And so these are all considered, the data has to be associated with rapid cycles of change. So that whole concept that you're going to make some adjustments in your program. So for example, in hand washing, if you know, if the first month you're 60% compliant, the next month you're 65% compliant, you need to make some adjustments within real time, if you're getting week-to-week data even, to make some adjustments to get you at that higher level quickly. So the rate of change is as important as the absolute change, if that makes sense. Let me just look here for Michelle's commentaries. Yeah, I think I covered all the points that she wanted to cover. She just comments that without baseline data, it's difficult to know whether you've actually made a change or demonstrated progress. So again, establishing the baseline is so important. And we've established the baseline with the loneliness scale. So good for everybody that's you know, gotten that baseline. One facility found out that 50% of their residents are not lonely at all, and another one felt that the survey demonstrated that there was a very high level of loneliness. So it's going to vary from facility to facility, but the important point is that scale then establishes for your facility what the composite score is. And so, for example, you would add up all the scores from each individual evaluated. You take the average of that, and you can also take the percent of people that scored 2 or higher on the scale, and then see if you can move the needle by some sort of intervention, one of which we're going to talk about here shortly, that might help with that loneliness scale. I think we're familiar with this. We saw this previously in terms of hand hygiene. So you can see that the template that's provided by Quality Health Associates, can help you score from month to month, identifying in the red where you don't meet your goal, and in the green when you do meet your goal. So this is something that's at a glance that can be shared with leadership. The graphs, I love the graphs, because you see that kind of wiggled line. It's like a roller coaster. And you can put arrows on that graph, arrows as to the inflections or the points of time that you did something new or different. Okay, so in the hand hygiene, it's just not simply doing the monitoring from month to month, but it's also like during those periods that you've dipped, like let's say in this case in September, you've gone down low, you would want to then interject a plan, do, study, act cycle for correcting that. And it may be just simply educating people or doing, some additional audits for, observation or the buddy system, where the buddies watch out for each other and doing proper hand hygiene. Good. Next slide, please. Yeah, so this is an example here of the short version of the UCLA loneliness scale. So we sent this out to folks. If you didn't get this or are not aware of that you got this, please let us know. We can send it out again. But this is a good example of a individual who is evaluated and checked off different components. And you can find, how each question was assessed, and then you get a total score. So the idea here is that you then add up all those scores from all the social isolation surveys, and you come up with an average score, and you can use that average score then to measure your interventions going forward. You can also use the data as a percent of individuals also. So that's another way to look at the population. So if 75% of your population scored, 2 or higher on 3 of the elements, then that's how you establish your percent for that particular scale. Okay, next slide, please. And then again, you can then map this to the Excel spreadsheet. where you've got, you've identified 20% of the individuals that are socially isolated, and then you can go through and see how many people pass the audits with future interventions.